Presentation: Partnering with Medicaid to Advance ECCS and Improve Lifelong Health and Well-Being, July 12, 2022. Vision: Healthy Communities, Healthy People. Logo: HRSA, Health Resources and Service Administration. Video feeds along right side.
Hello and welcome to Maximizing Early Childhood Comprehensive Systems and Medicaid Partnerships webinar. I am Cheryl Mathis from the Early Childhood Systems Technical Assistance and Coordination Center. The center has partnered with Kay Johnson on today's webinar to help ECCS awardees and their partners in efforts to effectively partner with Medicaid. And we are so pleased to see so many of our ECS awardees and your partners joining us for today's webinar.
Slide.
Before we move to introductions of today's speaker, I would like to review a few housekeeping items and technology reminders. Please mute your lines until you're speaking, just so we can cut down on background noise. We will be recording today's session and may share with awardees who are unable to attend today's webinar. And please feel free to use the chat box if you have questions or need assistance at any time during the webinar.
Slide: Profile picture.
So without further delay, it is my pleasure to introduce our webinar key speaker today, Kay Johnson. Kay Johnson is a nationally recognized professional. She is recognized for her work in maternal and child health policy as a researcher, an advocate, and a consultant. Kay is president of Johnson Group Consulting, Inc., which is a national firm based in Vermont since 1998. She's been active in Medicaid and EPSDT at the federal and state level. And she has served as a consultant and advisor to more than 45 states. Her expertise encompasses a range of women's, children's, family health issues, including perinatal and preconception care, home visiting, and of course, early childhood development, as well as many other areas. Kay has more than 100 policy reports and professional peer-reviewed journal articles, as well as more than 150 keynote and juried speeches. I could go on with many accolades and more description of her expertise, but we will stop there and just say we're delighted to have Kay join us today to share her expertise in connecting in partnership with Medicaid. Kay, I'll go ahead and turn it over to you now. Thank you.
Great. I need someone to give me permission to share my slides.
Gallery video and video call. Over 25 participants.
While that's happening, I just want to say I'm really delighted to be here. I am going to turn off my video while I talk to you because that will ensure a much better presentation on my part. And I am really delighted to be here with you today. As many of you may know, I've been working on early childhood comprehensive systems since the very first grants were given in the early 2000s by the Maternal and Child Health Bureau. And I've been working in some way on early childhood comprehensive systems since that time. So I'm going to talk about Medicaid and the way that I have learned to train people about understanding what Medicaid can finance is to teach them the 3 E's. You can use this test every time you have the question, what can Medicaid finance? It can finance something that is an eligible service for an eligible and enrolled child that is delivered by an eligible and enrolled provider. If it meets those 3 tests, then it's Medicaid can finance it. If it doesn't meet one of those tests, then you have to understand why. Is it that the provider is not a Medicaid provider? Is it that the service is not clearly articulated? Those are just a basic set of ways. So let's start by talking about eligible children.
Slide: The 3 E's for understanding Medicaid. Slide: Eligible children.
It's really important, Medicaid and CHIP matter for child health and equity.
Slide: Medicaid, CHIP matter for child health and equity. A bar graph: percentage of infants under 1 covered by Medicaid and CHIP, by race and ethnicity, U.S., 2019.
I like to say that we cannot have health equity for children unless Medicaid performs. Let's just go over those facts. Half of all babies, 2.1 million infants, are enrolled in Medicaid and CHIP. 6 out of 10 Black, Indigenous, and Latinx babies. And over half of all Black, Indigenous, and Latinx children of all ages, and 4 in 10 children with special health care needs. It's the driver of the healthcare system for children, and we can't ignore it, and we have to learn about it.
Slide, map of the U.S. color-coded according to percent of infants under 1 year in Medicaid who were not counted as enrolled for at least 90 days, 2018.
One way I've been thinking about enrollment is looking at infants' continuous enrollment. And since 1984, federal Medicaid law required that some babies were automatically and continuously enrolled for their first year. And since 2009, all newborns born to women covered by Medicaid for the child's birth are now covered as mandatory, categorically needy deemed infants. That means they are required to be covered, and they are required to be covered continuously for the first year and automatically as a baby. Families shouldn't even have to apply. Most states show a gap between the eligible number and those who are continuously enrolled for at least 90 days. And you can see there the quintiles on this map. We've got a low of 6%, which is great performance, to a high of 41%, which is really not great performance. And this study led me to see that it was variation in administrative practice that mattered. And why am I telling you this? A, because I know you want those babies to be continuously covered, but B, if states use the same approach for the continuous enrollment of women postpartum, that state will have the same weaknesses in their approach or the same strengths. And the report that's cited here has some best and promising practices used by states. I've studied them and cataloged them for you. Another way we need to think about enrollment and eligibility is about the post-COVID public health emergency, what people are calling the unwinding.
Slide, post-COVID public health emergency, PHE, Medicaid eligibility unwinding.
So HHS temporarily waived certain requirements to keep people from losing their coverage during the COVID public health emergency. But when it ends, states will be required to recheck everybody's eligibility. There are at least 6.7 million children who could lose their Medicaid or CHIP coverage, either because it's a procedural or a transition issue. That means they're still eligible, but the paperwork got lost. The family didn't get the letter in the mail. They didn't follow the instructions in the letter. A whole bunch of procedural reasons that kids could become uninsured. And there are a lot of state and child health champions working on this, about educating families, enlisting help from providers to educate families, using automatic renewals and electronic online processes by the state, using community outreach workers and call centers and outstationed eligibility workers, as well as a lot of other communication strategies. This seems to me something that really is a systems approach and in which ECCS should be aware of and perhaps participating in.
Slide, eligible Medicaid providers. Bullet point list.
Thinking about eligible providers, providers have to apply, be approved and enrolled. They have to be licensed. They have to be either approved by that state plan or working under a subcontract to a managed care plan. They should be in a qualified category, which the headlines on that are physicians, nurses, and doctors, psychiatrists, psychologists, and social workers, hospitals, clinics, and freestanding birth centers. But there are other kinds of providers that are sometimes referred to as unlicensed, such as community health workers, doulas, and case managers. And Medicaid can finance those types of services.
Slide, preventive services.
With a Medicaid state plan amendment known as a SPA, even though it's not pleasant, with a SPA, states can choose to reimburse preventive services recommended by a physician or other licensed practitioner within the scope of their practice. And this is a change. It used to say supervised or prescribed, and now federal law says it can be just recommended. So the pediatrician could recommend that the community health worker visit the home if the state adopts that kind of approach. It has to be done on a state-by-state basis and almost on a category by category. So they might have a spa for the community health worker and a spa for the doulas. California is a really good example where they've spent a lot of time with a lot of community input developing 2 spas.
Slide, eligible services.
Let's talk about eligible services.
Slide, poll. 1. Which of the following services for young children are being financed by one or more state Medicaid agencies? Select all that apply.
And first, we're going to start with a poll. So really thinking about, let's see, do I need to stop, do I need to stop sharing to get us to the poll? I'm not finding a way to stop sharing.
Kaylee can launch the poll for you.
Okay, good. All right, it is launching. Okay, we're going to go back up, and so the poll is asking about developmental screening, home visiting, dyadic parent-child mental health therapy, transportation to medical visits, and community health workers. And so the question is, which of those services is being financed by one or more state Medicaid agencies? Kaylee, let me know when you're ready to show results.
Okay, we still have people answering it, so we'll give it a few more seconds.
Okay.
And Kay, you have access to share your screen if you would like to.
Okay, I'm not. All right, let's just see if I can I'm having trouble getting back there. The Zoom controls have gone from me.
Okay, I'm gonna go ahead and end the poll.
Okay. Hold on one second. I am not. Oh, look at that. Well, you can see that there are varied answers. And the truth is, all of those things are being financed by one or more state Medicaid agencies. And you did quite well, actually. Most of you knew that most of them could be. And the community health workers and pediatric primary care, that's going on, but Oregon has a very special initiative about that you may want to learn about. And for some reason, folks, I am having trouble finding the Zoom controls are gone from me.
I'll share them for
Wait,
you.
I got it. I got it.
Okay.
Sorry. It just came back. Here we go. All right, now you see my garden. Back to the slides.
Slide, early periodic screening diagnostic and treatment, EPSDT, is the child health benefit package for Medicaid.
All right, so when we think about benefits, the first thing that we have to think about is the EPSDT, or early periodic screening diagnostic and treatment. That's the benefit package for Medicaid. It's not just the well child visits. It's not just a special side thing. Virtually everything that's financed by Medicaid for a child is financed as a result of the federal law that guides EPSDT. Very, very few exceptions. And EPSDT is about those well child visits, developmental, hearing, vision, dental, and mental health screening, as well as intervention services, and coverage for a wide array of services for children when medically necessary, even if they're not covered for adults.
Slide, well child visits and young children enrolled in Medicaid. Bar graph.
Let's look first at how are states doing on the well child visits. Well, overall, you can see the millions of children but in these under 6 groups who are enrolled in Medicaid, and you can see it's by default. I'm kind of just showing you the ratio, the number that had at least one well child visit. So of the babies, those babies should have gotten 7 visits, not 1. The toddlers should have gotten 2 per year and not 1. And the preschoolers should have gotten 1. But what you can see is that the visit completion and or the data reporting is not where it should be.
Slide, color-coded map of the U.S.
If we look at that by state, you can see the states in the salmon color are below the goal. The states in the gray are above the goal. The goal is a national performance goal of 80%. And that goal was set in 1990, and some states still haven't achieved it. It's really an area of work that you could be undertaking. And CMS says the goal is to assure that individual children get the health care they need when they need it, the right care to the right child at the right time in the right setting.
Slide. EPSDT provides enhanced benefits for children.
EPSDT provides these enhanced benefits for children. As I mentioned, there are no optional Medicaid services. So things that might be covered for children, even if not for adults, are like case management and mental health and dental care, OTPT, glasses, hearing aids. Those are very common examples of what Medicaid's buying for children that it doesn't always buy for adults in Medicaid. And then examples of how states are using financing to promote health and development of young children include the emphasis on screening with objective tools, developmental services and supports, parent-child dyadic mental health, both promotion and treatment services, and home visiting and other 2-gen approaches. The things that on the right are very specific to the young children and the kinds of things that you might be talking about in your ECCS initiatives. They don't require, for the most part, a new set of rules or requirements. There are some states that do seek approval to finance some of these things, but they're widely being financed, and we'll talk about that in a moment.
Slide. Broader systems financing to promote child health.
So I think we need broader systems financing to promote child health. And I think that Medicaid and pediatric primary care should be an anchor for early childhood systems. I just want to emphasize this moment of opportunity that if every state extends Medicaid postpartum coverage to 12 months, there will be 2 million mother-baby pairs that would have a full year of continuous coverage to finance services that prevent maternal and infant mortality and morbidity and promote child development and family well-being.
Slide. Use of key services among young children, U.S., 2019. Bar graph.
So I think, and many people are not fully convinced of this, but I and a few others continue to say it's time to apply the Willie-Sutton rule. If we're thinking about early childhood systems, we need to start where the children are. The children are in healthcare. 90% of them are getting a preventive or well child visit. 4.4 million toddlers are getting an EPSDT visit. There are only a little over half, about 55% of children in this age group that are in early care and education childcare for more than 10 hours a week. There are only, say, 5 to 7%, it's really 2 to 7% of children who are in Part C early intervention, and only 2 to 3% who are in formal home visiting programs. We have to start where the children are. If you're building a system out of something where only half of the kids are being seen, you're not building a system. All these elements need to be in, and other elements, the system's design, but we have to have healthcare.
Slide. Design for a high-performing medical home.
One of the things that I've been talking about for a number of years, and I published in some work that I did with Charles Bruner, is a design for a high-performing medical home for young children in Medicaid. It's a redesign, and it talks about redesigned well child visits that are holistic and team-based, that are comprehensive well child visits based on the Bright Futures guidelines and EPSDT rules, that are family-centered, relational, strengths-based, and use 2-generational approaches, and that are used doing all the recommended screening elements that are in the Bright Futures guidelines. And the second thing that this high-performing medical home would have is relational care coordination. Every medical home by definition has routine care coordination. This would have more intensive care coordination available as needed. It would have relational staff such as community health workers or family specialists whose job it is to do that care coordination, and it would ensure more effective responses and linkage to the community. And it would embed or link to other services and enhance support. So it might be using the models that can be co-located in primary care, such as Reach Out and Read, or Dulce, or Healthy Steps, or the video program BIP. It might have integrated mental health, or it might be doing effective referrals to or linkages with services such as home visiting, early intervention, mental health, dental care, all of those things. So it really is of strengthening and a redesign.
Slide, why high-performing medical homes for young children in Medicaid.
So why do that? Well, first of all, we need more team-based preventive and family-driven care. The AAP policies and guidelines now call upon providers to support early relational health, respond to social determinants of health, and address the impact of racism. We need to do better to respond at all of those levels. It would ensure more delivery of and linkages to the other early childhood services and more system connections. It would increase the value and the impact on health long-term, on development and family well-being, and it would give a better return on investment by doing enhanced pediatric primary care. I call this high-performing medical home. I'm calling it that because I want there to be quality standards and measures and payments like there are for medical homes certified like a geriatrician would have. But I know other people and call it enhanced pediatric primary care. Other people call it advanced pediatric primary care.
Slide, examples of evidence-based services for young children and families. Development, basic needs, home visiting, mental health, parent support, relational.
I'm not going to go over this slide in detail, but David Willis and I, working with National Academy of Sciences reports, pulled out some examples of the evidence-based services for young children. Many of these can be and are being financed by Medicaid. Some of them are not. And so it's just a little food for thought for you to think about that.
Slide, poll 2. What are components of an advanced or high-performing medical home? Check all that apply.
So we're going to do our second poll. You can go ahead and put that up. Do I need to stop sharing? Let's just be sure I get it right this time. No, I don't. All right. So what are the components? Enhanced care coordination, augmentations such as Reach Out and Read, team-based care, childcare services, maternal depression screening. Tell you now, for those of you who have done your checkoffs, there are a lot of references at the end of my slides. So you have the file. If you want to learn more about the high performing medical home, there's a short 4-page piece. There's a longish, 20-page chapter from a long report. There's a lot there that you can dig into if this is a topic of interest. How are we doing, Kaylee?
We have about 18 responses and it looks like it's slowed down. So I'm going to go ahead and close the poll.
All right. So everybody got the care coordination piece. Most of everybody got augmentations like Reach Out and Read. Terrific. And team-based care, yes. Not childcare services. That's correct. So about half of you, I'm just going to say, Medicaid should not be directly financing childcare services. It might be financing some health support or some inclusive childcare or for some children with special health care needs, but it should not be directly financing childcare services, the day-to-day work of the teacher in the classroom. Okay, moving right along.
Slide, examples of early childhood finance opportunities in Medicaid.
I know that you can't read this slide. This is your teaser. This is the kind of thing that's in the handout for today. And it talks about ways that you can find better well-child visits in primary care, ways to approach the care coordination case management issue, developmental services, children with special health care needs, early childhood mental health, and then system and finance changing such as better reimbursement for transformation, personnel who are being used, data, and other mechanisms. This is just a little teaser for what's in a longer handout, and I really encourage you to look at it, use it as part of your discussions and your planning.
Slide, state Medicaid action, and progress.
There's been a lot of state Medicaid action and progress on this topic. I've been working on it for I've been working on early childhood systems for about 20 years. I've been working on Medicaid for kids for about 40 years. But the real surge over the past 5 to 10 has been very, very gratifying. States really are seeing this, and partly because the proportion of children that are in Medicaid, it's received more attention. But 39 states have done Medicaid eligibility expansions, which mainly affects parents, but it also affects women of childbearing age and men who don't yet have children, and helps them get in good health for their planning pregnancies if they choose to have them. The Medicaid postpartum eligibility extension, 19 have moved ahead. There are 14 more in the planning stages. We will be well over half by the end of the year. Using EPSDT to finance comprehensive well visits. Those initiatives are going on in a number of states, and financing elements of the high-performing medical home. Massachusetts comes closest to adopting a whole model that looks like what I showed you, but California and Washington State have pulled off big pieces, like the community health workers, like the doulas, like the financing healthy steps, and other related work is going on in Colorado, Connecticut, New York, North Carolina, Oregon, Rhode Island, and in the states that have Centers for Medicaid and Medicare Services, Inc. projects funded. If your state's not on this list and you think it should be, you can put that in the chat. There is Medicaid financing for key services and the workforce. More than 22 states are financing home visiting, and I've given you a link to my report about that. Most states are using it for early intervention. NCCP tells us more than 30 states are using it for infant early childhood mental health, and that survey is being updated as we speak, so we'll have a new and up-to-date number for that in the next few months. Community health workers in pediatric primary care, 1 to 2 states, most recently an exciting advance in Washington State that's gone all in on this kind of improving medical home for young children, and doulas in 5 to 6 states, and that's a growing number as well. More than 30 states have had enhanced prenatal care or perinatal case management for many, many years. Some of those programs are not as strong or connected to the system as they should be. And there's group prenatal care being financed in an estimated 9 states.
Slide, Emerging Consensus on Priority Areas for State Action in Medicaid, Title V, and ECCS.
There also are some priorities that people have sort of said at the moment. Some of these are longstanding and some of these are time sensitive. So I mentioned the unwinding of eligibility post-COVID, making sure that those 6+ million kids don't fall out of Medicaid, also catching up on their visits that were missed during COVID. Strengthening early childhood comprehensive systems to include more of the healthcare field, incentivizing the high-performing medical homes, and embedding those other evidence-based models into primary care, which we talked about, that relational workforce with community health workers, care coordinators, family specialists. And I think that really can relate to those that are thinking about the early childhood systems transformation that may call for that new kind of relational workforce. Expanding the capacity of child development experts to be in pediatric primary care. Action by state Medicaid programs related to social determinants of health and 2-generation approaches, although a lot of the social determinants work has been focused on adults and not families with children embedded in them. Using the contracts and other mechanisms with managed care and other health systems to actually tighten the language in the contract to get more performance. Extending the Medicaid postpartum coverage to 12 months so that you've got a parallel to the infant continuous coverage, and then supporting the dyadic services for the mom and the baby during the year postpartum. I think that's the biggest opportunity on the table for us right now, is to figure out how to get that mom and that baby everything they need and that they should be served with during that 1 year of continuous coverage, getting them off to the right start. States can also adopt continuous coverage for a longer period in the early childhood years, and then ways to advance equity with more data, training, and oversight to eliminate bias and unequal treatment is another growing trend.
Slide, Poll 3.
Let's do poll 3 to find out in your ECCS discussions and plans, what are those priorities for child health and Medicaid? Are you focused on financing developmental screening? This is a check all that apply. Are you focused on more comprehensive, high-performing medical homes, managed care contracts, the EPSDT visits, or the visit schedule, financing home visiting, community health workers, doulas, and other non-licensed providers, or the postpartum coverage? These are sort of the ones that many states are focused on right now based on my reading of state reports to HRSA and my reading of data and policy action. So how are we doing, Kaylee?
We have answers still coming in
Good.
steadily, so we'll give it a few more seconds, about 10 more seconds. Okay, I'm going to go ahead and close the poll.
Okay. Well, I'm not surprised. Financing for developmental screening, that came through in an analysis we did last year working with AMCHIP. David Willis and I worked with AMCHIP to look at ECCS and Title V and McVie reports, and developmental screening definitely came up. I'm hoping to boost that high-performing medical home share. I've given you a reference to a report about managed care contract provisions if you want to get a little primer on that. The visit schedule is improved in most states for the youngest children. Again, we're getting close to half the states are doing home visiting financing, but that should be an area, know your state status. And then working on the provider side and the most Medicaid postpartum expansion. Great.
Slide, Early Childhood Systems Partnerships, Experience, and Best Practices.
So let's talk about early childhood systems partnerships, experience, and best practice in the context of today's topic.
Slide, Avoid strategies that often fail in partnership.
I think things that we've learned over the years, things that you want to avoid, are going into this without learning Medicaid priorities, approaches, and terms. I have seen more efforts fail when a group of people who are either on the education side or on the public health side or even on the healthcare pediatric side get an idea and run it up the flagpole to Medicaid without learning about priorities, approaches, and terms. And what I say they usually get in that case, the response is talk to the hand. We don't do what you're talking about. You've got to couch your approaches and conversations with them in terms that make sense in their worldview. Don't approach Medicaid as the bank. I've heard many, many Medicaid directors say, we are not the bank. Come to us with win-win strategies. What's in it for us? What's in it for you? We're not just going to give you money. We're not the bank. Using Medicaid as one funder braided with others. The first time this really struck me was in a large meeting about early childhood mental health, and I finished a plenary talk and someone said, so, tell me how we're going to fund early childhood mental health with Medicaid. And I said, the question is, how are we going to use Medicaid as one funder braided with others to get this done? It's not going to be the answer for everything. Broadening the ECCS thinking about the role of healthcare and their providers, engaging experts and advocates to help you define and refine issues, really get them into context, and recognizing that Medicaid financing is not intended for early care and education services or child health services. I'll tell you, there's a bright line even for school nurses around what's educational and what's health. So I would not start there.
Slide, Approaches for Advancing Medicaid Partnerships.
These are some approaches that I think are promising for advancing Medicaid partnerships, and they're really common sense. Many of you have built partnerships before. You're doing it in your systems work. And first, about building relationships with the people you want to be in partnership with. One way to start is with the EPSDT or child health staff in the Medicaid agency. They're probably familiar with the kind of talk you're doing, and they're closer to the issue. And then overall, engaging the agency and health plans and pediatric providers in your discussions, and getting the Title V MCH program staff involved as well. Defining a shared agenda by aligning a subset of your priorities to Medicaid priorities. Looks like developmental screening, it may be one of those. And then translating your issues into Medicaid language and approaches. And again, in that matrix handout, there are examples of the kind of language one might use to do that translation. Identifying the mechanisms and levers through contract provisions, guidance to families and providers, the change in definition of the medical home, quality initiatives, performance improvement, measurement, and enrollment and eligibility processes, particularly in the case of the babies, the postpartum women, and the unwinding. It used to be that people would just go around and say, oh, you know, we need to increase provider rates. Well, what we've learned over the years is that increasing provider rates didn't necessarily get us the results that we needed. We can't have provider rates that are extremely low, but increasing provider rates has not proven the method to drive change for the families.
Slide, alignment of select national measures for monitoring child health prenatal to 5 years. 2 tables.
So this is a chart that looks at a comparison and alignment of various sets of measures. I used a chart like this a lot when I was working with Medicaid and Title V and McV agencies and trying to get Medicaid financing for home visiting. And this does not include all of the measures in any set, but it includes a very large sample of what's aligned. And particularly the McV, it's mostly the health measures. But you can, when someone looks at this and they see all those checks, they say, oh, we have common interest in a shared outcome. How are we going to work together to build toward that shared improved outcome? It really changes people's perspective about what you're doing and about what they're doing. And I think from a systems point of view, this kind of thinking can be really helpful to you.
Slide, summary of federal law requirements for Title V and Medicaid partnerships.
Many of you know that Title V and Medicaid are required by federal law to have partnerships. In particular, they must enter into interagency agreements together. They must coordinate and share information and data. On the Medicaid side, they need to use Title V programs to provide services, and they have to reimburse them when they're services to Medicaid beneficiaries. And on the Title V side, they're assigned the role to help coordinate EPSDT services and help with outreach and enrollment and report on numbers and ensure no duplication of effort. So every state has an interagency agreement. Many of them are quite general.
Slide, poll 4.
Our fourth poll is a harder one, but I'm asking you what types of activities and areas of responsibility are part of your state's required Title V and Medicaid interagency agreement, sometimes called the MOU. This is again, check all that apply.
1. Data sharing. 2. EPSDT coordination. 3. Outreach and enrollment. 4. Payment for Title V clinical services. 5. Don't know.
We'll give it about 5 more seconds for people to answer.
That's great. Okay. Well, it's better than I expected. I expected more than 2/3 to say I don't know. So you exceeded my expectations. Most people don't know what's in those agreements. Data sharing is the most common thing. virtually every agreement talks about payment for the clinical services. So if you didn't find it there, or you were guessing, that number should be a little bit higher. So here's the thing. I know they have in the past. HRSA has a relatively up-to-date set of those MOUs, interagency agreements, available as submitted by Title V agencies. I did a review of those a couple of years ago, and the National Academy for State Health Policy I reviewed about 8. National Academy for State Health Policy reviewed the whole set, and there's a review of them at Georgetown, the MCH library as well. You could really learn a lot about maybe some special language or just having the conversation and the negotiation of that agreement about some language related to early childhood systems or systems of care for children. It's an opportunity. It's a mechanism. Some states like them general, they don't like to do specifics, but having the conversation even about why no specifics would be helpful.
Slide, state governance collaboration and system building.
So another element that really matters in all of this is the state governance collaboration and system building on both sides. So what we know is that the structure of early childhood governance bodies define what receives attention and resources. And where ECCS governance bodies are coordinated or merged, greater progress has been achieved. We've documented that in a qualitative study last year, but many states don't have Medicaid or health professionals represented at their ECCS governance tables. And this is an opportunity. There may be somebody there from public health, but not from Medicaid. Also, Medicaid may have a child health or EPSDT advisory group. Pediatric leaders typically are members of that, but it could be that ECCS or MCH leaders could join or at least attend some of those meetings or get on the agenda for some of those meetings to have a conversation about some of these priorities when you're ready for that.
Slide, system thinking, mapping and planning is important. Diagram.
I think system thinking is so much of what you're doing. And this is a sample system map from early childhood services from a toolkit I put together based on state leadership workshops in 18 states funded by HRSA MCHB. And under my contract, and one of the things we would do in these workshops is I would go to the flip chart or I would go to the whiteboard and I would draw the big circle that was the pediatric medical home. And then we would talk about the fact that they have an obligation to refer, starting at age 1, to the pediatric dental home, and that they have an obligation to do the well child visit, also known as the EPSDT exam. And then the question is, well, is a problem detected? That's the EPSDT core question. If not, then they might just go back the next time a well child visit was due. If yes, they might return or repeat to the medical home to get another screen, to get diagnosis and treatment services, to get care coordination support, or they might be referred out to other places in the early childhood system. And these bubbles on the right represent the key elements, the most frequently mentioned elements that states gave us when we had them do this system thinking. There is instructions for how to do this as an exercise in this toolkit. We can make that available to you if anybody wants to do it. It's relatively straightforward, but a facilitated discussion really helps people visibly see how is the health system, or how is the health system not connected to other pieces of the early childhood system.
Slide, ECCS grantees promising and proposed actions. Bullet point list.
So all of you have been thinking about this, and some of you have some promising and proposed actions, such as engaging the staff for Medicaid, including them on your advisory boards, engaging experts in Medicaid, attending and participating in Medicaid work groups and meetings, participating in Medicaid advocacy initiatives, working on a specific issue of mutual interest. The most common are around coverage, developmental service or maternal depression screening, infant early childhood and dyadic mental health therapy, financing for doula and community health workers, which we saw in the poll, home visiting, structured coordinated referral, or data systems work. And then collaboratively developing a shared agenda for ambitious states, working with providers on quality and linkages, engaging with managed care and accountable care organizations, good for you, Rhode Island, and monitoring other state Medicaid policy and legislation, learning from others. I'm sure that there more of you could be listed in this. This is what I have from the documents that you submitted to the Technical Assistance Coordination Center in HRSA.
Slide, discussion, and questions. Closes presentation.
So with that, I'm going to stop. I'm going to stop sharing and we can go to some questions, and I will turn back on my video. See if I can put the chat up here.
Thanks, Kay. We have a question from Lisa Jackson in the chat. She says, though not directly related to the content of the presentation, I'm curious how the use of virtual or telehealth services are being addressed. We're seeing greater utilization and access to child services through this technology among rural families.
Well, thanks, Lisa. That's a terrific question and probably something I should have put on my emerging priorities list. It certainly is a priority in child health and it is being discussed. And the widespread belief is that the Center for Medicaid and Medicare Services, CMS, is not going to go back, that they're going to continue to allow states the wide flexibility around telehealth, telemedicine that they allowed during the pandemic. And exactly how those rules will look has not come out, but the talk is that they're not going back and that states really are doing it. For those of you who didn't, who had that only on a very limited basis in your state, you might want to look into. So your state may have applied only for the emergency and they may need now to go back and turn in a state plan amendment. So they kind of turn on the switch for this broader array of telehealth services. The switch is through a state plan amendment beyond the emergency. So really good question. I think CMS is going to be very lenient on those. Noting that the handout, it was sent and it's also, if you can, download it from the chat. So Chris, where do you go to learn your state's Medicaid agency's priorities and concerns? I think attending meetings is probably the way to do it. A lot of this isn't written down. A lot of it isn't in reports. They're not like public health or early childhood agencies where they issue a lot of reports and make a lot of pronouncements. They are really busy driving change in the healthcare industry. And a lot of what they do is proprietary with managed care organizations or with providers. So knowing their priorities is very often, you might see it in the governor's budget. You might see it in a Medicaid director's or Medicaid agency budget. If the Medicaid director makes an announcement, in big states, they often do. In small states, you may have to go look at the budget and see what they submitted for. But I think attending meetings and listening or asking, you could always write a letter and ask them about their priorities, I think. So good question about what would be deemed Title V clinical services. Well, we don't have them so much anymore. When those federal laws were written, it might be as much as half as the kids in a state were being served for well child care through a public health Title V MCH funded clinic. And we don't have a lot of public health funded Title V clinics anymore. When managed care rose, more kids were covered by Medicaid and more pediatric providers were starting to see kids through Medicaid. Pretty much the federal government said, you know, let's pull back, let's not have Title V spend all of its money on something that will be covered by Medicaid. There are still places where public health county level clinics or urban clinics are still in operation and are still delivering particularly preventive services to families. So those would be Title V clinical services. Services for children with special healthcare needs would be another category on the non-preventive side. Chris is forwarding, what can ECCS leaders and their partners do to increase the number of children receiving care in a high-performing medical home? I think this is where we, no surprise how much time did I spend on it. I think this is where we have to start hammering and just say, look at how many children didn't get their well child visits. Look at how many babies didn't have their continuous care. Look at other performance criteria. We've got those core measures, and I showed you the measures and the links to the set on the official set are there, but look at, the sum total, even a year by year basis, but in that first 30 months of life, on the quality measures, what share of children got the services that they need. It's a starting point. And I think really then saying our children need something more. I think making the argument that healthcare is the linchpin of the system for young children. If they think that everybody is just looking at childcare, they're not worried about what they're doing for you. It is not always a priority for Medicaid, not because they don't care about it, but more because it's not a big cost driver. They're not spending a lot of money on it. And even though it might be 40 or 50% of the population that they cover, most of the costs are in older adults and seniors and people with disability. And they're over there trying to control costs and manage chronic conditions and doing all of those things. So Medicaid directors will tell us again and again, you're a little part of my budget. I don't pay very much attention to you. That is almost a direct quote from a state Medicaid director at a meeting convened by MCHB and CMS. So I think start by gathering your facts and putting together, you can liberally use the little orientation piece that was as part of the materials for today, and make yourself a little fact sheet, and then start there saying our kids aren't getting what they need, our youngest kids aren't getting what they need. You can, say 22 other states do home visiting, X number of states are doing infant early childhood mental health. Our state isn't doing this. If you think the comparisons are helpful, and if not, just the internal comparison. Sometimes you can compare plans on those performance measures. And I think showing that performance is uneven and that you need attention to quality across all of these medical homes. I think, and if they're starting to get on the community health worker bandwagon, be sure your voice is heard to say, not just community health workers for adults, seniors, and people with disability. We need community health workers for families with young children. And sometimes we've forgotten to get to that table, and the community health workers are all being deployed for adults and seniors. So I think those are my basic ways to do that. You can call me for more strategy. So what does a social determinants of health approach that focuses on families, not adults alone, look like? I think that's really important, Chris. And I think one of the things that, if we go to our principles around, could some people turn on their cameras? It's really hard to sit here and talk to all those little black boxes. Thank you, Erica, Darby, Lori, others. Okay, so much better. Really, I don't feel like I'm here all by myself anymore. So I think, again, when they're looking at social determinants, some things are going to be the same. Let's say the plans are looking at housing, right? But maybe they're only prioritizing housing for adults with disabilities. Again, you need to remind them that families with young children may need that help with housing as well. Here in Vermont, we have an accountable care organization, and they got some extra money to work on social determinants initiative. And our then Title V director, very wisely, Brina Holmes, she went and she said, oh, by the way, I want to do some high performing medical homes, and I want to add Dulce to pediatric medical homes in the state of Vermont. And they got 3 years worth of a demonstration project out of it because there was money there and nobody had gone to ask. And they can obviously see the need to coordinate the care and address the needs of people who are living on the street, which they mainly see as adults, forgetting that there are families living without homes as well. So it's, again, reminding them, elevating the issues, letting the voice be heard. So that's one whole angle on that. I think the other thing is to remember, if we're thinking about the importance of safe, stable, and nurturing relationships, that the parent-child relationship in and of itself is part of the social determinants. It's the context, it's for that child, it's the water in which they swim. And so saying to them, a lot of these social determinants and social, emotional, behavioral issues are going to be driven by what happens in those first 1,000 days. And we really want to improve services so that we're building a lifetime of health by, and that's how they ended up with this community health workers in pediatric primary care focused on young children to promote early relational health in Washington state, advanced by the Medicaid agency after they were really sold by leaders in pediatrics, and the Provider Association, early childhood leaders, and then they took it to the legislature, they got the money, they had the support of the governor. So figuring out what your ask is and taking it forward. Other questions? I think we're just about at time. I'd be happy to take another question. I would really encourage people to go to the EPSDT website, at the HRSA EPSDT website. We spent a lot of time translating that so that it really could speak to you. It's a very good primer about what EPSDT can do, and it doesn't take long to look at it. It's not very long, it's a website. Another thing I would encourage you to do if you're going to go deeper is look at the short piece. I think it's 4 pages about the operational principles for a high performing medical home, and just get a written recap of what I was trying to describe to you quickly today, and see, again, some states are moving this component by component. In California, you know, they moved kind of the preventive mental health and healthy steps. They moved the doulas, they moved the community health workers. They're moving it component by component. In Massachusetts, they rewrote the proposal that would go in the managed care contract for Mass Health, so that it would actually be defining and what they call an advanced medical home. And it has very similar components to what I described to you. So it could be piece by piece, or it could be a bundle of things. I know that in her work, in the work in Bridgeport, Janice, I've just lost Janice's last name. It'll come back to me. Janice is actually, she's a very sophisticated advocate. They've moved this whole thing they call a baby bundle. And once they got that all off the ground as a community-led initiative, they moved on to now she's really tackling it, learning it with Medicaid. And, you know, she comes with questions. I'm her expert. You probably have your own, or you can find one, and says, what do they mean by this? What do these data mean that they gave to me? She started asking them for detailed data that aren't published. What do we know? How are the plans performing? How many babies got served? How many babies got kicked off? Asking questions. And she's been involved now for over 6 months in a really functional working relationship. And they're all in at this point, her Medicaid agency. Last question. Becca, Kaylee, I should turn it back over to you.
Okay, great. Thanks, Kay. Of course, if anybody has any questions, reach out to Kay. Or if you can't find her information, reach out to us and we can get that to you.